Welcome back. I'm Michael Stamatinus, your host of the Advancing Healthcare Innovation Show. And if you're new to us, we're extraordinarily passionate about healthcare innovation and adoption within healthcare. And there's really two factors that hinge on that. One is this notion of access, and secondarily is leadership. And there are leaders that are coming to some very influential roles today that aren't necessarily, they're not necessarily tech savvy, rather they're tech dependent. And one of those leaders today that I'm just delighted to have on is Sonia Panigrahy. She's the Senior Director of Clinical Excellence and Innovation with Community Healthcare Association of New York State. Sonia, welcome to the show.
Great, thank you, Michael. It's a pleasure.
Awesome.
So
well, let's maybe open up a little bit about sort of your background. I think your background is so interesting from a human-centered design standpoint. I want to really kind of hone in on that theme today. So maybe let's start a little bit about your background and then jump right into it.
Absolutely. So my background, I have a master's in public health, also some degrees in economics and global health studies, and I quickly fell in love with healthcare management and working within the provider setting. So I've worked in hospitals and clinics, kind of in the role of quality improvement or performance improvement. So really focused on, how do you identify poor outcomes, whether they're clinical, financial, or operational. So for example, denied claims or high no-show rates among patients or long wait times that we have all experienced. And how do you really break down those problems and kind of identify those root causes so that you can begin to problem solve? And what I noticed is that a lot of the processes or systems that were breaking down, leading to poor outcomes, often had root causes that were in two buckets. They were technical and they were human. And I think in healthcare, we borrowed from other industries like manufacturing industries to figure out the technical fixes, such as, Lean, Six Sigma, Agile, the PDSA. But we really lacked a lot of methods for understanding the human behavior. And the human behavior meaning those that are providing the healthcare services, we call them providers, or your clinical care teams. We were also lacking a way to understand the human error that was happening among our patients, whether those are your wealthy patients or your low-income patients that I currently work with in community health centers across New York State. And what I realized with the problem of not understanding human behavior is that we missed the mark in healthcare by creating solutions that are ill-fitted. They don't meet the need. They're riddled with guesses and biases. Oh, patients are uneducated or they just don't understand. And so we waste a lot of time and resources creating solutions that don't work. And I think we have a moral obligation to really take the time to understand our patients, understand our providers providing care, to create better solutions.
It sounds like you have kind of backed into how you define innovation, which is first seeking to understand, and then once you really know that environment, figuring out where the blockers are and removing those blockers. And sometimes the innovation might not necessarily have to be a technological advancement. It sounds like it could be an improvement in sort of human performance. So I'd love to maybe know a little bit more about sort of how you've taken that mindset and approach and applied it into a population, with some of the federally qualified health centers that you're working with. And what does that look like when it's being done at scale?
I'll do my best to answer that question. What I would like to mention with the patients that I work with, mostly right Medicaid uninsured, is they're a population that's really high in volume and high in cost. So I think there's a lot of interest in creating solutions for this patient population. I can speak to cases around the overutilization of the emergency room, inappropriate, very costly. We're now seeing that example with vaccine hesitancy. right? We have had the vaccines since December and are still trying to figure out why patients are hesitant to take the vaccine. Also looking at chronic diseases that are preventable, and we have ways of managing them, but we have patients that still lack the ability to manage their conditions, that kind of spun into complications and avoidable deaths. One of the examples that I worked on was identifying why patients are overusing the ER. And I partnered with a physician in Cambridge, Massachusetts. And the idea was really to just understand their narrative and to figure out what is their contextual background of who they are as people that lead them into going to the ER. So it was a labor-intensive study because it required doing a lot of kind of sitting down with patients and talking to them for 90 minutes, doing a qualitative study, analyzing the data. But the things that we found were quite fascinating and actually matched a lot of what we're seeing in literature. Patients had a lot of childhood trauma, economic stress, so financial instability. And as a result of this, a lot of them suffered social isolation in their adulthood, which is a strong predictor of high ER use. And so as a hospital administrator and a clinic administrator, when we identify that, what patients need is not actually insurance and enrollment into an insurance plan or knowing who their PCP is or more visits with their PCP, they actually need a different kind of support system, which may actually be a case manager who can really work with that patient and help connect them to the social needs that they have. I would love to see more of this being done with vaccine hesitancy. Working in the healthcare space, we make assumptions about different groups, about why they don't want to be vaccinated. And I think we really need to have a more robust way of identifying themes among different groups. So say New York, you've got your Black and brown populations, you have your Orthodox Jewish populations, and you have your white conservative populations. Low vaccine rates, all for different reasons. And if we had taken the time to do the user research back in December, I think we would have gotten ahead of the curve and not be struggling now, especially as the Delta variant is starting to take hold. And now we're really starting to feel an urgency.
It's interesting that you pointed that out as, end result is the same about having that hesitancy, yet the reason for it is, it differs in taking that. So when you take the time to actually understand that, we talk about, in this show, we focus on real people that are really innovating and that are implementing and executing. How do you execute on something like that? How do you, from the tactical point of view, reach out to those specific groups after you've understood the reasoning behind it? I mean, is it possible to even change someone's opinion if they're vehemently against something? Is that even a possibility?
That's a great question. I think if you are working within the healthcare space, if you're a provider, and let's say we'll take the example of chronic diseases, which is a bread and butter diagnoses for primary care. So say hypertension, heart disease, diabetes. When you start to find trends, so say you look at your quantitative data, which is really valued in healthcare and with their physicians, and you're starting to notice a trend that your A1Cs are going up and they're uncontrolled, or your blood pressures are out of control. I think it's important at that time to find, clinics have a quality improvement department. I think what needs to happen is these departments need to start incorporating human-centered design or user experience into their methods to identify the different groups that are experiencing uncontrolled vitals, and sitting down and understanding how to talk to them in a way that's very empathetic and curious and willing to take the time to sit down and ask questions that are not defensive, but really getting a full picture of who that patient is and not blaming them and not approaching them as though as, why are you not showing up to your appointments? Why are you not taking your medications? It's explain what happened to me yesterday when you went to the emergency room? Can you explain what was going on in your day? And oftentimes the patients have very rational and legitimate reasons for not showing up to the doctor's office or not taking their medications that have nothing to do with lack of education or lack of respect for the doctor's time. They have other things that they need to deal with that triumph going to the doctor or taking their medication. So I think it's more of an understanding of, for patients who are willing to make a change, identifying that there are maybe some different kinds of supports they need to get to the doctor's office or to take their medications that are probably very simple and very low cost. But if we don't take the time to ask, we'll never know how to help.
It's incredible how you just pointed something out, which is selection of words,
Yes.
and the right selection of words elicit different responses. So for example, when you started and framed the question of if you're asking a patient why, the word why, for whatever reason, and I don't have, statistical evidence right here to kind of notate, I can just only tell you anecdotally, personally, when someone asks me a why-oriented question, it brings up defensiveness. And maybe because, when I was younger and I, made some foolish mistakes, my parents would be like, well, why are you doing this? Why are you doing this? So, I don't know. Maybe it's that.
Yeah.
And the way that you notated how to kind of re-articulate that question and maybe framing it from, instead of a why, you can say, well, you turned it into a what or how, or, what was going on yesterday that caused you to, really miss the appointment. And then what you can do is you can get, as you mentioned, a clearer picture as to what's going on in the world of that particular patient. And maybe from their standpoint, if it falls on their priority stack, or maybe it didn't, because they needed to do something else that was like an imminent priority. So it's interesting that even being able to change the selection of words and languaging, how that can get you a really good result. And, that's not technology. I mean, that's, you said it, that's displaying a level of tactical empathy to really connect with people. And maybe in this time, especially over the course of this pandemic, it's, you've had to display, or at least clinicians have had to display, a level of empathy for patients. We've also had to display empathy for providers as well. And can you maybe go into a little bit more, examples of some wins in those areas, as well as maybe some things that haven't worked out so well, and what were the reasons, behind, some of the setbacks?
Absolutely. And if I may take a step back, I think your point about how we ask questions is probably the hardest part of the whole human-centered design process. And I've coached teams on how to have a dialogue. And it's very difficult as adults and as professionals to sit back and not try to solve problems prematurely, but really just go in with the curiosity and know that, my value as a researcher is to ask questions, to get as much information as I can. And people have a really hard time with that, which has been surprising to me, but I think is pretty critical. In a lot of human centered design, there is a method about how you observe and speak to your end user to get information. And while it's open-ended, it is structured to make sure that your innovators' needs and questions are being met and themed and coded correctly. So I'd say with healthcare, I've had some struggles. I think it's an area or an industry where human-centered design still hasn't really taken hold. I'm seeing, a lot of this methodology comes from the technology product management side. And I think there is so much application in health and social services that we miss. You just mentioned providers, and we talk so much about provider burnout. And we make assumptions about why providers are burning out. And we think it's just, oh, well, they're clicking a lot, so we need to figure out how to reduce clicks, or we need to give them more data, which, by the way, providers don't want. And if anyone wants to speak to me afterwards, I can explain why. um, so I think there's maybe less wins and more opportunities where we really need to realize if we want to improve access to care, quality of care, experience either providing or receiving care, we need to do a better job of talking to people to understand what is it that they actually need, and then designing and developing products and testing it with their end users to make sure it's what they need. And so we're talking about maternal health outcomes. We're talking about provider burnout. We're talking about, how do we increase marginalized populations to get the vaccine? How do we help patients manage their chronic diseases? These are all, I think, areas of opportunity that whether you're designing a service or a product, user-centered design will help, I think, really validate that an idea is a good idea, and help to inform the business plans. We often, when we build programs, there's supposed to be a needs assessment. And I think the reason why 80% of products fail is that needs assessment is not really thorough, because we're not asking the right questions and going to the people who will be using and adopting our product. And I'll say I've worked with a few entrepreneurs who took a year off. Then they decided to do some user research when they weren't getting traction, only to realize they were trying to meet a need that really didn't exist. And that's a shame to have wasted that much time and the resources creating something that people won't use. So I think for investors, this would be such a great investment to have somebody do some user research, vet some of these ideas before they're funded and rolled out to execution.
Access means is defined differently to different people. In the lens of the entrepreneur, access might mean having difficulty getting their product, their solution, their idea in the hands or in front of the right people. Have you found that the pandemic has actually sped up the level of access because of the need, for solutions, or have you still seen that there's a barrier there?
A little bit of both. I think, working in New York State, it's a heavily regulated state. We have been wanting to do telehealth for years. But the pandemic, it kind of overnight changed our ability to provide telehealth because regulations were lifted, HIPAA compliance issues were lifted, and reimbursement was now put in place. So we saw a lot of quick innovation. And I always say primary care is a place where innovation happens very quickly. Low resourced, but I think the desire to innovate is really in this space. I think patients, I just saw some data, definitely wanted to do telehealth, and we saw a lot of patients from 2019 to 2020 increased their use of telehealth, either audio or audiovisual. So I think that's really promising. What we need to do is to, again, do some user research with patients at home and make sure that the telehealth setup is working for them. I've heard anecdotally from people who are providing behavioral health services that telehealth is not always wanted in a patient's home based on their home environment. The lack of privacy, family members around. Some patients would rather be back in the clinic office where they could have protected space with the therapist. We, I think, assume patients want telehealth, and we need to just make sure that it is in fact the way they want to receive care. They have the home environment, and they also have the technology to do it. I think we also need to, look to our providers. I think we assume that providers love telehealth and it gives them more flexibility in their work life. But I'm not so sure that's always true. A lot of providers miss the face-to-face interaction with patients. And there are a lot of logistical challenges with telehealth. So for example, in the clinic, if a patient comes in, you've got your front desk staff collecting consents, demographic information, patient then goes to the exam room where a medical assistant takes their vitals, and then the doctor's called in to see the patient. But in the telehealth world, all of those roles get convoluted.
Nice.
And we're finding more is falling on the provider for telehealth visits.
Right. What, you mentioned the word assuming a number of times throughout our conversation. How much data is enough data? How much research is enough? When do you know that you've done enough user research to then actually then start to execute?
That's such an interesting question because the answer is not intuitive. Um, Again, having gone through a master's program where I took biostatistics and I've had to show data to surgeons who are asking about confidence intervals and p-values, um, user research is more, there's more of a value on the qualitative data, which, as I mentioned with my ER example, is very time consuming because you're spending a lot of time with people. Time consuming also equates to expensive. But what the research shows is that for a group of people called a persona, so a persona are people who exhibit similar characteristics and therefore needs. So maybe for, or looking at hypertension, looking at males, African American urban settings, will be a different persona from white women in their 30s rural setting. Different issues, different needs. For each persona, you only need to interview 5 people. Typically after 3, you start to identify patterns. And then you have 2 more people just to validate the patterns that you're seeing. The idea, especially in the product management world, if 3 people are experiencing the same frustration, that warrants enough of a reason to put in resources to fix their problem. So if 3 people are experiencing it, you can extrapolate that to a larger population. And I
It's a
know
good
that
rule of
it's a
thumb.
lot of people in healthcare very uncomfortable, but I've done a number of these projects. I worked with a provider who wanted to do 10, 15, 20. We saw the same themes. We came up with the same needs after 3 to 5.
That's really interesting to know that. And just sort of moving ahead. I mean, where do you see things moving, and what would you like to see? From an innovation adoption standpoint, from solutions providers, where do you see the gaps? Where do you see areas of opportunities?
I think for innovation teams that are working in the health and social service space or the technology space, right? There's a lot of technology innovation in healthcare. Um, I think it's really quite critical to adopting kind of user experience research. Anytime that somebody has just started with an idea and before it goes forward. So I think for investors, when you are, entertaining companies to fund, really making sure that they've done their homework and really understand their end user and a market fit to have, to be part of that 20% that will actually succeed. Um, as I mentioned before, I think there's a moral obligation if you're creating something to improve somebody's health and well-being to not do that research. And then financially,
Yeah.
I think there's also an obligation to making sure your dollars are being well spent. And somebody who does user research, is part of a framework where, you start out with very robust user research. You inform the innovation team, like hear what the users are saying they need, have that inform the design and development of your product, have them create a prototype that is based on the user's needs. So somebody like myself is the advocate for the user. Put that prototype in front of your end user and test it in front of them. Don't wait till your product has launched. You do that as an iteration, cheap, quick to fail, test it with your users, tweak it again, finalize it, and put it into market. I think what happens is people build ideas based on assumptions and biases. They launch it, realize after the fact it needs to be fixed, and you're all of a sudden running against very costly changes that could have been prevented if they were done earlier.
Yeah, so it seems like, products, solutions, they're made or broken in the beginning, not in
Correct,
the end. And you
correct.
would much rather do that work up front so that you know where the other opportunities lie to make improvements. And I mean, that's really what it is to be in a startup is getting that the rapid feedback and continuing to evolve and iterate. And then also at the same token, even on the provider level, having the openness to to be able to look at workflows and see where there can be improvements. And I know that from a performance improvement standpoint, that's something that you and your teams are constantly evaluating.
Correct. Yeah, and I think what happens is when you're open to the bigger picture, there are a lot of surprises and what we call aha moments that just kind of make people realize that there are all of these hidden opportunities that they would not have known otherwise had they not taken that time to understand, either for a provider, like how their colleagues operate and what their needs are, or their end patient, which is always to me, I think, one of the most fun parts of doing this work.
So like let's talk about aha moments. I mean, has there been an aha moment that has really stood out to you over the course of the last 6-12 months that you're like, wow, that's really worth noting? If so, what would be?
Yeah, I think in a field kind of adjacent to healthcare, I was working with an entrepreneur who was building a platform for caregivers. And it was a job hunting platform. And realized that caregivers actually had a pretty easy time looking for jobs. Apparently, they're still using Craigslist, which was new to us. Craigslist and Indeed. So her competition was already something that her end user wanted to use. But through our user research interviews, um, a lot of the caregivers spoke about having a lot of pride in working for employers that did professional training. And they looked for skills in training. One caregiver said, she had to do a procedure and had to look on YouTube to figure out how to do it. And I think we saw a number of caregivers who said, I wish we could have more trainings to help me feel more professional and confident in the work that I do. And so the entrepreneur is now pivoting her business model, realizing that caregivers, what they really needed was not a place to find jobs. It was a place to get better training. And B, during the pandemic, what an amazing opportunity to do an online module that's really much more scalable across any type of firm who's hiring and placing caregivers, to have an educational platform in place.
That's awesome. It's a nice aha moment. um, when I think about how I define innovation is about adding value to many, and I'd be remiss if I didn't notate to the audience that you are a published author. um, and you know if you mind maybe sharing a little bit about the context of Nina Neighborhood Ninja, just because it is one of my son's favorite nighttime books that we read. Can you share a little bit about that?
That is, thank you for bringing that up. So I think part of my own, um, I was always a bookworm as a kid. And as I became an adult, I wanted to share the love of reading with, my friends and my siblings that were having children. And I realized through my own journey of looking for books, kind of realized in this day and age that a lot of the books are still divided by gender, binary gender, boys and girls. And, the boys got a lot of the really cool action, adventure, problem solving storylines, plots. And the girls still were kind of on the sidelines, kind of decorating homes and in the princess mode. And I thought this is so unfortunate that we still kind of help, when children are learning about the world and their role in it, that we are shaping their view of that through the books that we're giving them. I was a kid back in the 70s and 80s, and, I started realizing this problem in the early 2000s. Not much had changed. So I spent a year really, I think, talking to parents and teachers, kind of understanding from them, like, what are the needs that you're seeing kind of in the books that you're trying to select for your children. and realized that my book did not exist. This was 2016. So I took some time and published a book called Nina the Neighborhood Ninja, also translated in Spanish, that's really just meant to fill a void I saw to get more females represented as a main lead. Right now, boys and animals are more represented than the women who make up half of the world in the US.
Yeah.
And it also, I said, why not make her a person of color? Because I was also not seeing that um, in the pages of the books I was reading. And the book has still been selling. I've sold every month that it's been out and getting great feedback, like from Michael's son, about how, even for a boy, like they appreciate seeing a strong female who uses her brains, uses her muscles, gets a little dirty to kind of solve problems. And our problem solving is really led by empathy, which I think is a theme that every parent would want their children to learn from.
Yeah, absolutely. And yet another validation point that you practice what you preach from a human-centered design standpoint, doing the research, doing the user research, and figuring out where the opportunities are, where the gaps are. How can some of the audience members, follow your work, and how can they kind of get a hold of you?
Um, my name is Sonia Panigrahy. Or else Sonia, last name Panigrahy. I have a website, soniapanigrahy.com, where I talk about my book. You can also Google me and find me on LinkedIn. And I'm welcome to anyone contacting me if you want more information, either about user experience as it applies to healthcare innovation or the children's book.
Awesome. Sonia, it's been such a pleasure to have you. And if for the audience members, if you found the content helpful for you today, or would you mind, sharing this on social media, whether it's with your network? And we're just always so grateful when we have guests that can come on that really share their areas of expertise, and when it actually makes a difference to advance healthcare forward, because at the end of the day, we need more innovators. We need more action takers and doers in our community. So we're thankful for you. And Sonia, it's always a pleasure to chat with you, and enjoyed just kind of learning something new again. So I'm looking forward to our next conversation.
Great, thank you, Michael. Very passionate about this work, and really, hope that folks take what we spoke about to heart. And as I said, I'm happy to kind of reply to anyone who wants to learn more. Maybe have me support some of their efforts.
Awesome. Well, great. Well, we'll see you soon.
Sounds good. Thank you.
Bye.